Our next speaker is Dr. Bob Tamburro. He's a senior advisor for clinical research at the Eunice Shriver National Institute of Child Health and Human Development. He's a board-certified pediatric critical care and hospice and palliative care medicine physician who serves as a senior advisor for clinical research in the NICHD's Division of Extramural Research. He is going to be speaking to us today about the new network model they have for proposals to support clinical studies through the various networks at the NICHD. Tamburro.
Thank you. Well, thank you, and how exciting to be here today. And I want to thank the MPRINT team for giving us this opportunity to share our program. NICHD has a long tradition of supporting multi-site clinical research. Here is a report from nearly 50 years ago in which the NICHD supported a 9-center study assessing the value of amniocentesis during the second trimester. Not long thereafter, plans for formalizing this support in the form of clinical research networks began. In 1986, NICHD formed its first 2 clinical networks, the neonatal intensive care units, the current neonatal research network, and the maternal fetal medicine units, with the explicit goal to perform large-scale clinical trials and to provide a faster, more effective system of evaluating neonatal intensive care and maternal fetal treatments. In the ensuing 35 years, these networks have conducted seminal research that has advanced these fields and impacted and informed clinical care and practice. Since then, the NICHD has continued to expand. Let's see if the slide keeps moving. There we go. Got through all of them coming up in a hurry. But long story, how do I go backwards, Fred? There we go. All right. We'll get this right this time. But long story short, since then, NICHD has continued to expand its network research portfolio, identifying other networks to satisfy other areas of its mission. And we could see a number of those landmark articles popping up on the screen. With all the success, the question is, then why change? Why has NICHD undergone this new approach to look at its clinical trial networks to try to improve it and enhance them? And I think to begin to answer that question, I want to take you back to 2016. When Hillary Clinton and Donald Trump had their first presidential debate, when Ed Sheeran won the Grammy for Song of the Year, Thinking Out Loud, and in presenting the award, Stevie Wonder offered in his presentation that every single thing should be made accessible to every individual with a disability. And when people heard the word corona, they thought of a beer and not of a virus. And when the NIH proposed and subsequently implemented a series of reforms to enhance clinical trial stewardship and transparency, and thereby further assure the success of the NIH clinical trial enterprise. As part of this initiative, and to provide NIH institutes and centers flexibility across their different scientific areas, individual institutes and centers were tasked to develop their own clinical trial funding opportunities to address research priorities and their strategic goals. In response, the NICHD reaffirmed its commitment to conducting rigorous multi-site clinical trials and identified 4 guiding principles of that research. In the fall of 2019, those principles and that commitment were expressed in a guide notice and reasserted in a webinar. The 4 guiding principles that were expressed and emphasized in those forums included to enhance the rigor and reproducibility of clinical trial protocols, to promote greater availability of multi-site clinical trial infrastructure to support trials from a wider range of investigators, to facilitate data sharing and access to biospecimens to efficiently expand research capacity for all investigators, and to facilitate greater involvement of diverse populations in multi-site clinical trials. We believe that adhering to these principles ensures proper stewardship of public funds, increases accountability, and helps the NICHD maintain the public's trust. However, a process is needed to operationalize these guiding principles. To best inform this process, an extensive assessment was conducted. First, the NICHD published a request for information, notice 19041, following Dr. Bianchi's webinar in November of 2019. And I suspect many in this audience may have responded to that RFI, and it had the explicit goal of soliciting input from the public on its vision for supporting multi-site clinical trials infrastructure. There was a fairly robust response to the RFI, with 79 responses received and 19 coordinated messages from professional societies and associations. A number of common themes were expressed, including, I apologize, it's a little bit delayed here, but we'll figure it out. A number of commonalities were expressed, and based on this feedback and the input, NICHD has opted for a centralized approach in which network infrastructure will continue to be supported. There was a time when we weren't sure if we were going to continue our network infrastructure support, but based on that, very extensive assessment, the decision was, yep, let's continue to maintain a centralized approach. Let's continue to support network infrastructure. In addition, I think there were some very important things. We decided that we would now permit access to our network resources from any qualified investigator in the extramural community. The mantra being, nobody has a monopoly on good ideas. There's a good idea somewhere out in this country. Let's allow that investigator to utilize the investment we're putting into our networks to operationalize their idea. In addition, we also decided that all network clinical research applications will undergo NIH peer review. And we believe that it's these two changes that represent the most fundamental changes of our new approach. All right, first, to enhance rigor and reproducibility, we have developed a new protocol proposal and selection process. Within this initiative, trials to be conducted within network infrastructure will now be submitted as individual NIH applications, will undergo NIH peer review, and funding decisions will be made by NICHD leadership with the informed and necessary second-level review provided by our council. This is a huge difference from our previous practice. Before, networks were provided funding as part of their infrastructure awards to develop and conduct research projects with their own internal review, but with no need for NIH peer review and with no need to secure additional funding. Let's see if we get it to go this time. There we go. Second, to promote greater availability of multi-site clinical trial infrastructure to a wider range of investigators, this new initiative, as I just mentioned, will permit any investigator from the extramural community to propose studies to be conducted in our networks. Certainly, investigators from within our funded, easy for me to say, our funded network clinical centers will be eligible to propose studies via this funding opportunity. And we anticipate, and it's been, to some degree, our experience, that a large number of proposals will still originate from that source. However, independent of the source of the investigator, studies will need to align with the purpose, the goals and objectives of the network and with NICHD priorities. All right, there we go. Facilitating data sharing and access to biospecimens is the top priority of this initiative. Networks will be required to share data and biospecimens according to the NIH policy for data management and sharing. In addition, clinical trial study consent forms will be modeled to allow broad sharing and future use of the data. Further, the use of common data elements, both within individual networks and across our networks, will be a priority. Finally, And importantly, it is critical that we continue to facilitate greater involvement of diverse populations in our multi-site clinical studies, including those individuals with disabilities. And I say continue because I believe this has long been a priority and important consideration for our clinical networks. Ensuring diversity in multi-site clinical trials includes both the study participants, obviously, but additionally, diversity among the investigators. Thus, NICHD studies will be expected to maximize inclusion of diverse study participants, and we will work to continue to develop diversity in the workforce as described in Guide Notice 20031. In order to optimize the successful implementation of this new approach, 4 main components were addressed. They include identifying the science we hope to support with the mechanism and assuring its alignment with the appropriate networks, developing and implementing a rigorous pre-application selection process, assuring a judicious peer review process with the necessary expertise and yet free from any conflicts or perceived conflicts of interest, in keeping with the longstanding excellence of NIH peer review, and finally, identifying the most effective and cost-efficient method or methods to fund this research. In identifying the science that we hope to support with this initiative, the plan is to start small and expand progressively. Most major transitions are associated with many hurdles and obstacles, some anticipated and some not, and I can assure you this initiative has been no exception. Consequently, our plan has been to start small, monitor, reassess frequently, learn from our experience, modify, and then progress accordingly. We plan to begin by applying this approach to just a handful of our networks. In doing so, we hope to identify synergy, and you'll hear me mention that word frequently during this talk, between these networks to further optimize our research and leverage our resources. I believe the philosophy driving this new design was best stated by Dr. Rohan Hazra, our Division of Extramural Research Director, when he stated that it's not important for us to be right, but that collectively we get it right. We could only do that with the informed and candid feedback from stakeholders and investigators like yourselves, and thus the reason we value the opportunity to be at the MPRINT annual meeting. Next, we believe that there needs to be a rigorous pre-application process that will not only assess the feasibility to determine if a project can likely be successfully completed by the network, but will also review the science to be sure that it is relevant to the current state of the field, to pressing societal needs, to the network mission, and to the NICHD. A third key to successfully operating this new initiative is indeed the peer review process. Having clinical trials undergo NIH peer review as a separate application is one of the fundamental changes of this initiative and will go a long way to enhance the rigor and transparency desired. Finally, the funding of this initiative is obviously a fundamental component. To begin, the goal is to remain grossly cost neutral with our current investment in multi-site clinical trials. That said, the hope being that with more effective utilization of our clinical network infrastructure, we will be able to optimize our investment such that we support the best science in the most timely and cost-effective manner possible. In attempting to identify and develop the best model, we reached out to other NIH and federal programs as suggested in the RFI response. Again, a major change in this new initiative is that the funding for capitation dollars to conduct the individual projects will no longer be provided as part of the network infrastructure, but will only be awarded through the peer review process. Incorporating this feedback, these goals in many internal assessments, and in development over the past 8 years, we issued Funding Opportunity Announcement, PAR 23037, in late November of 2022 to operationalize this process. The purpose of this PAR is to invite applications for large-scale, multi-site clinical trials and observational studies developed in conjunction with NICHD networks that will be conducted using NICHD-supported network infrastructure. These multi-site clinical projects will be submitted as investigator-initiated multi-PI grant applications by any qualified investigator including network investigators, in conjunction with the respective networks data coordinating center. It is the goal that these projects will utilize the NICHD Clinical Research Network infrastructure to promote the funding and support of the best science in a timely, transparent, equitable, and cost-effective manner. As a reminder, the goal is to start small and expand progressively. So the initial networks to be included in this initiative are the maternal fetal medicine units, the neonatal research network, the Global Network for Women and Children's Health Research, the Collaborative Pediatric Critical Care Research Network, and the Pelvic Floor Disorders Network. That said, if an investigator is considering a project that aligns with another NICHD network or another area of science not directly aligned with the 5 networks listed, they are advised to contact the NICHD scientific research contact, namely me, but to use our global mailbox listed on the bottom of the slide. So what is our process? Well, to briefly review, it's a 5-step process in which we start with the researcher submitting a letter of inquiry at least 4 and probably 8 months prior to the application receipt date, particularly for non-network investigators. The researcher prepares and submits a concept proposal if their letter of inquiry is approved to do so. When we receive that concept proposal, we will conduct our own internal review, and we will also ask the respective network to review the concept proposal and to share their input. That said, at the end of the day, NICHD leadership makes the final decision on which concept proposals can be developed into full grant applications. The concept proposal is approved by our leadership. The researcher, the network begin to work together to jointly develop an application to be submitted in response to PAR 23037. And you could see the link to our pre-application process. And as Aaron mentioned, and I thank the MPRINT organizing committee for doing that, it's on one of the rotating slides during the breaks. But please don't hesitate to reach out to any of us. So what's our progress to date? Well, the PAR, as I said, was published November 28th in 2022. We received our first letter of inquiry December 2nd, 2022, literally in less than a week. This showed up, and you know how it is when you start a new initiative. It's like, oh my gosh, the door's already open. But we had published the notice of intent to publish. So I think a lot of investigators were just waiting for the PAR to be put out. Since then, we received nearly 50 letters of inquiry. And I think encouragingly, nearly half, well over 40%, have come from non-network investigators. So really reaching to that point of opening our networks beyond just the network investigators. In terms of concept proposals, we received our first concept proposal a few months later in March of 2023. To date, we've received over 20 concept proposals, and nearly a third of those have been from non-network investigators. Our initial application deadline was June 5th, so published late November. June 5th, we received 3 applications. Our scientific review branch that oversees the special emphasis panel that reviews these applications really was ready to go. They organized a very robust review in mid-September. And to date, we've received 10 applications in response to PAR 23037 that have been approved through our relatively rigorous pre-application process. To maybe give you some perspective and comparing this with the infrastructure, the Neonatal Research Network Awards and the Maternal Fetal Medicine Unit Infrastructure Awards were published in April of 2023. So really, we were developing this new funding approach while the next cycle of the infrastructure was being provided. And really, that's created a lot of challenges for us in moving forward. Well, I mentioned that this all started 8 years ago, right, when there was a call for concern about NIH clinical research. But it seems that concerns still exist. Here's a blog that was posted a year ago, January, in which the writer suggested that the NIH should form a clinical trials committee to address some of the concerns related to the clinical research. Many of the concerns mentioned in that blog, we believe are and or will be addressed by our network initiative. Specific comments that were made: the clinical trial ecosystem has many systematic flaws. Trials are far too expensive, cumbersome, and slow. Numerous reviews have found that over 80% of standard medical guidelines do not have high quality evidence to support them. Of the more than 1,100 NIH-supported trials completed in 2020, the median sample size was only 57. Only slightly over 100 trials, less than 100%, had a sample size of 500 or more, and less than 5% had a sample size over 1,000. And I think most interestingly, they contended that making human clinical trials less expensive and quicker is probably one of the biggest opportunities for improving healthcare in the United States. As I'm sure this audience is well aware, Dr. Monica Bertagnoli, pictured here during her induction ceremony, was relatively recently appointed as the NIH director. In his nomination of Dr. Bertagnoli, President Biden offered that Dr. Bertagnoli's vision and leadership will ensure that the NIH continues to be an engine of innovation to improve the health of the American people. Thus, innovation will seemingly be a top priority for the NIH and for our networks. During her time as the National Cancer Institute director, Dr. Bertagnoli shared many of the sentiments of our network initiative, starting with, in her first core principle, calling for a modernization of clinical trials. In addition, listed among her 8 core principles were several related to the 4 guiding principles, and we hope to be addressed by our network initiative. For example, ensuring equitable delivery of evidence-based cancer prevention and treatments would seem to align well with our goal of increased rigor and reproducibility. Her call for increased diversity in the cancer research and care workforce would seem to align, one, with our call for investigators from a wider range of institutions, as well as our goal number 4, to increase diversity, not only in our participants, but in our investigators. Expand data sharing certainly is spot on with our principle number 3. And finally, to increase collection and use of data, particularly from underrepresented populations, clearly aligns with what we're hoping to achieve with our guiding principle number 4. And then I want to mention, she also mentioned strengthening partnerships with NCI and other clinical groups. And I think this call for synergy, and as I mentioned earlier, is clearly a goal of our new initiative. Specifically and relevant to our discussion today, we believe that synergy with the MPRINT program holds the potential to advance many of the projects to be supported by our institute and conducted by our clinical research networks. As we look to the future, and also as described before, we have started small and monitored progress closely, and we will continue to do so to identify the best process and practices moving forward. We have learned much during our initial year and a half of this initiative, and have attempted to adjust our program accordingly. One issue that we are continually working to improve is assuring equity between our network and non-network investigators, which is a huge challenge, as you might imagine. How can a single investigator compete with a committee of the most accomplished investigators in the field? We have learned much. We have adjusted our process accordingly, but we have much, much more to learn. As we move forward, our goal is to support network trials that are innovative, trials that utilize novel and innovative designs that facilitate faster, simpler, more flexible, and less expensive research, and that assess innovative interventions that are of higher impact, studies that hold the potential to inform national treatment guidelines and or to provide new US FDA indications and labeling. We believe MPRINT can be a vital cog in those efforts. The ability to be integrated with clinical practice. Research and clinical care should not be siloed efforts. They should be integrated such that they inform and facilitate each other. And finally, projects that yield results that can be implemented in a timely and effective manner. The research cannot end with the publication of a landmark paper and the posting of the data. Projects must be designed with plans for timely implementation of actionable results. We believe collaborating with the highly successful MPRINT programs holds the potential to facilitate these goals. This vision has been considered and incorporated from the very inception of this new approach to our network research. And I want to thank Aaron for his consistent efforts, leadership, and input to drive that collaboration. For example, in our published PAR 23037, we explicitly direct investigators to the MPRINT program as we include the sentence, applications proposing to assess maternal or pediatric therapeutic interventions are encouraged to utilize resources available via NICHD's Maternal and Pediatric Precision and Therapeutics Hub. Similarly, if you go to our website, and again, it was on the rotating slides for the break, there's a description of our pre-application process. And again, we explicitly describe our recommendation to utilize MPRINT resources with the sentence, once a concept proposal is approved, the investigator proposing the project will work with the network and potentially other NICHD supported resources. And again, specifically calling out MPRINT to collaboratively develop a grant application. And so in closing, I just want to thank MPRINT for all the effort, insight, and expertise that you provide in advancing maternal and pediatric therapeutics, and for this opportunity to share our thoughts in our new program with you. So thank you very much.
So are there any questions for Dr. Tamburro before we move to our panel discussion?
Hi, thank you for the talk. My name is Tamara Lewis. I'm a neonatologist and pediatric clinical pharmacologist in Toronto. I was maybe one of those 79 people that responded to the RFI that Dr. Bianchi's group put out about how to improve the neonatal research network in particular. And my question for you is about, when investigator-initiated clinical trials are designed, oftentimes I'll say card-carrying clinical pharmacologists may not be involved with some of the key steps in clinical trial design, like dose selection, dose ranging, exposure response considerations. And so, one potential would be that NIH provides like a clinical pharmacology core or some kind of clinical pharmacology consult service when people are designing their trials to consider very simple things like, is the dose they're using rational? Is there an opportunity to collect PK information, exposure response information, et cetera? So has the NICHD considered providing that type of input when clinical trial applications come in?
Yeah, so great question. And I'm not sure I could speak for all of NICHD, but I'll certainly share some thoughts and invite Aaron and I see Nahida over there if they have anything that they would like to share. Yeah, it's a great question because a lot of our network clinical research does focus on medications, therapeutics, and identifies different levels. When I was the project scientist for our collaborative pediatric critical care research network, that was one of the projects we did looking at GM-CSF, trying to identify the best mode of delivery and the most effective and yet safest dose for a subsequent clinical trial. I think a lot of the work that our pharmacology branch is doing is trying to, push us in that direction so that we have resources such as MPRINT that when our networks are struggling with these sort of, decisions, and as you, so eloquently pointed out, could really impact the overall value of the entire study if we don't get that right from the get-go. And so one of the things we'll do in our pre-application review, if we think there is that need for that, we will put that in there to say, hey, we would suggest that you reach out to identify the appropriate expertise to help inform that. Now, fortunately, a lot of our networks do have some of that expertise embedded within their investigators and so forth, but it's not uniformly available. And I think it's a really important point that you make.
Thank you.
Thank you. Please, Aaron.
To partly respond to Tamara's question. So that is one of the visions we've had for the MPRINT Hub, is to provide that clinical pharmacology expertise to network trials and other trials that come in. So I think a really good thing to think as you hear the next set of talks in the panel presentation, because I don't think there's been a lot of inquiries to the MPRINT Hub. So, how can we enhance that? Right? Or what are the most appropriate intersection points? I'm sure, Sarah and Legg don't want all 80 concept proposals going to them beforehand, right? But this is really something we'd like to talk about at the meeting.
don't want to break this, but I'm shorter than the last person. I'm
I could
Rachel,
empathize, so thank you.
I'm Rachel Greenberg from Duke and Pediatric Trials Network. So, I was going to say actually something very, very similar to Tamara, and I'm also a neonatologist. So I think about things, through the, what I've seen on the Neonatal Research Network as well, in addition to PTN, and can see a lot of, I think, synergies among that are possibilities that haven't been realized yet. And in particular, it seems, in a lot of the clinical trials that are funded or people get excited about, they're excited about that, 500, 1,000 patient trial on that particular molecule that everybody's excited about. But has all of the groundwork been done, in the initial studies that maybe are a little less flashy, maybe a little less, quote, innovative, but, then or maybe even natural history studies to show, to adequately make sure we have the right sample size and, I think what are the opportunities, I guess, within this mechanism to ensure that I think in the peer review process, sometimes it's like you want to fund the exciting things that are going to like make a difference right now, but the long game is sometimes missed in terms of the groundwork. So that was maybe more of a comment than a question, but your thoughts.
Yeah, no, and I appreciate it. And I think you make some good, really good points that the best study in the world, if it's not going to be implementable at the end, we've basically wasted millions of dollars. And I think, as I shared in our my brief presentation, I think that's going to be a huge priority for NICHD going forward. We just created our Office of Clinical Research. Our founding director's expertise is in the implementation of clinical research. So I think getting a study designed from the get-go and doing all that work on the front as you described, such that at the end we have results that are actionable and readily implementable, has got to be our goal. And I think the only way we can do that is by having the appropriate expertise at the table at the beginning. And I reach out to this group. You guys are, the experts. We're open to thoughts. We're open to ideas. I think our pharmacology and our pregnancy and perinatology branches are very open to new and novel ideas. And so, let's continue the discussion because we want to learn from your expertise and we want to get this right. As Dr. Hazra, has said, it's not for us putting something out there and say this is perfect, but by working together with our investigators to figure out how to get it there. So thank you.
Thanks.
Thank you.